Chloe works with Salesforce in the Chief Medical Officer organization and is responsible for innovative, evidence-based whole person healthcare and making it more accessible through innovative digital means. And before joining Salesforce, she helped scale up one of the largest telehealth companies in Canada. So Chloe is based in Montreal, our only non-US based speaker. All right, Chloe, take it from here.
Sorry, Atul, I'm having trouble with Zoom to pull up the right desktop. So just
Okay.
give me a second. Are
Take
you
your time.
seeing? Yeah, so.
No, I'm not seeing anything yet.
Okay.
Yeah, now we see your video.
Okay, great. Sorry, I think I needed to leave. It wouldn't be a 2020 if I didn't have some technical issues, right? Okay, so I think if this is.
Yeah, it's starting to screen share now. Yeah, we can see your slide. Your
You can see
screen.
the slide when virtual care becomes simply care.
Yes.
Okay, we've got this. Sorry, everyone. So hi, I'm really excited to be here today to talk to you about a transformation that we've been seeing for the last few months, but definitely for the last few years in the making of virtual modalities becoming more readily accepted, integrated, and really expected by patients, providers, and pretty much every stakeholder in the healthcare and life sciences space. So before I get started, I do want to say thank you to Atul and DigExchange for having me today. I want to say thank you to all of you for your time and for your patience with some technical difficulties getting started. Similarly to Luke and Ruby's sessions, we will be having a Q&A, so please make sure to write in your questions in the Q&A section so I can make sure to address them. A little bit about me. My name's Chloe. I'm a clinician based in Montreal. As Atul said, you can maybe see the wintry wonderland behind me. I'm a consummate health nerd, and about 5 years ago, I left traditional clinical practice and really started working at the intersection of technology and healthcare. And I'm very excited about making whole person care more accessible through technology. So, quick disclaimer, virtual care is obviously a really broad topic and there's no way we can cover it in 27 minutes. So I'm going to really do a quick 30,000 foot view overview. And if there are specific topics that you're more interested in or want to hear more about, please let myself or Atul know and maybe we could do something in the future on that. During the presentation today, we're going to do a really quick overview on what I mean by virtual care because there's a lot of confusion between virtual care, telehealth, telemedicine. They're sometimes used interchangeably, but they're really not the same thing. Then we're going to review some industry trends and obviously speak about COVID-19 as a catalyst for change. Then we're going to do a slightly deeper dive on 4 use cases in virtual care and show how they tie back to the quadruple aim, which is a value framework that is used extensively in the healthcare and life sciences industry. And then finally, we're going to look at a few things to keep in mind as we are setting up this new digital future. So for reference, when you hear me say HLS, that's just me abbreviating healthcare and life sciences. I know it's a bad habit to use acronyms, but it can get quite a mouthful. So virtual care. What most people say when they're saying telehealth and virtual care and using them interchangeably, they're really referencing this tiny element, which is telehealth, which is connecting a provider and a patient through a video modality. And virtual care is so much broader than that. It really is a full ecosystem. Virtual care is simply care that's augmented by technologies that inform, personalize, and accelerate humans' abilities to care for one another. It's relevant across the entire HLS industry in providers, payers, pharmaceutical, med devices, and public sector are all undergoing this digital transformation. It's really important to also understand that this is continuously evolving. This care delivery encompasses so much more than simple video consultations and includes a wide array of digital health pathways like health and wellness apps and chronic care management, remote monitoring, digital trials, and so much more. Every part of the HLS industry and other industries, as we heard from Ruby, are being disrupted and impacted by this digital transformation. So quickly, these are some examples of how this is being applied today in different parts of the industry. So you might see here in medical devices, we've got connected devices, we have AI, we have algorithms as a medical device, we have smart pills, we have virtual selling, decentralized trials, virtual patient support programs. On the payer provider side, we've got obviously virtual consults and network management, onboarding your team, ensuring that your team is up to date, credentialing, digital front door, like we heard about from Luke. And across all of them, we've got hospital at home, which we're going to be looking at a little bit further in the presentation. Speeding through here. So looking at some healthcare industry trends, and we're all very, very familiar with these, but I do think that they bear repeating. That obviously COVID-19 was a great accelerator for innovation, but really the industry's been in flux and been subject to these trends for some time. So changing demographics, 10,000 Americans age into Medicare each day. With that comes a lot of complexity and very specific healthcare needs. Cost of care, $3.5 trillion was spent on American healthcare alone in 2017. We're not even talking about outcomes here. Provider shortage and burnout. There's a predicted shortage of 12 million healthcare professionals globally by 2030. In the US, 120,000 physicians are expected to be, a shortage of 120,000 physicians by 2030, and 49,000 of those are PCPs, primary care practitioners. So that really starts to bring up a conversation of how are we making sure that primary care, which is more important than ever, is accessible. And increased consumerism. We saw it in Ruby's presentation. Really, every industry has gotten the message that today's customer, so patients, wants a similarly transparent and user-friendly experience. So they don't want to be able to do groceries and have them delivered to their home, but have to call to make an appointment and leave 6 voicemails with their provider office. It just doesn't make sense. There's a lot of cognitive dissonance there. And then more specifically with regards to virtual care, there were already trends in the making prior to COVID-19. So we saw increased patient demand. Over 70% of the population was interested in using virtual care. Special shout out to here, you might be surprised, I was, that over 50% of the 55 plus population was also interested, which is sometimes a population that we don't think of as interested in digital transformation. Increased provider adoption, it went up 340% between 2015 and 2019. That's pretty radical. Expanding regulatory approval, we had 29 states that had joined a licensure compact. I won't talk about licensure here because it's very messy, it's very long, and we can have a whole talk on that. But reimbursement, very key here. None of this change is possible if we can't be reimbursed for it. So over 100 new CPT codes were already in place. 37 states had parity laws, which means that they were paying the same for a virtual consultation as for a in-person consultation. All of this really set the stage for this big transformation that we've seen over the last 9 months. Excuse me. So, COVID-19. Obviously, it bears without saying, our world is turned upside down and we all have to adapt very fast. Healthcare has notoriously fallen behind the times in terms of technological progress and innovation, especially when we compare it to other industries. But the pandemic has created many crises, and one silver lining is that it really accelerated our industry's pace of growth and change. Let's take a look at some numbers for post-COVID or during COVID. We're not quite post-COVID yet. I got a little ahead of myself. So in 2019, 11% of the US population used virtual care. In 2020, over 45%. And just as a caveat, those are Q2 numbers, so by now it's even higher. It's a really drastic increase when you think about it. Providers saw 50 to 175% increase in their virtual consultations. The problem is that these increases occurred sometimes, well, often over very short periods of time, sometimes weeks, mostly days. Providers had to really hastily put things together and put these temporary solutions that were built with digital tools that were not made to sustain a more long-term vision. Patients have now come to expect telehealth, and many providers are now more comfortable with it. So we really need to start thinking about how do we set a more sustainable digital future. Let's take a quick look at the market, because this is a really great indicator of what's to come. So it's been a pretty wild funding landscape. If you've been keeping up, we've seen $9.4 billion in investment in digital health through Q3 alone. We've seen SPACs. We've seen one of the biggest deals in history, which was the Teladoc Livongo acquisition for $18.5 billion. Obviously, there's been urgent demand, in part due to helping manage the response to COVID-19, but what we're really seeing is that the market is indicating that this is here to stay, and providers and every stakeholder is thinking about what tools they're going to need in this new future. So I know that was a really fast zipping through, just setting us up for some baseline stuff, but I do want to spend a bit more time on the use cases. So quickly, before I jump into the use cases, I just want to talk about the quadruple aim, which I mentioned a bit earlier, which is the value framework that we use across healthcare and life sciences. So it's important to know because it has 4 pillars, and really we're always trying to think about, if I'm proposing a new innovation or a change in process or just a new way of delivering care like virtual care, it should ideally be acting on at least one of these levers so that it can justify why we're implementing it. And these levers are supposed to be enabling the delivery of high value care. So the 4 pillars are improving the health of populations, enhancing the experience of care for individuals, improving provider, and this is all providers, so that's not just physicians, but it can be caregivers, it can be allied health professionals, engagement and retention, and reducing per capita cost of healthcare. So, this will definitely sound very familiar to you, but really good to level set here. So let's just think about this shift to virtual care and care anywhere and meeting patients where they are. Obviously, that improves access to care and patient outcomes. That improves clinician and provider experiences by allowing some of them to work from home or reduce the burden placed on an emergency room. It optimizes workflows to reduce care inefficiencies, to reduce cost. Yes, you name it, the possibilities are endless. So let's look at use case number 1, virtual behavioral health. In the wake of the pandemic, its economics aftershocks, a staggering 40% of Americans recently reported experiencing one or more adverse behavioral or mental health concerns. That's really high. That's almost half of the population. And this is just the ones who report it. So obviously, this is quite a stigmatized space. It's becoming less so, but we are definitely not reaching everybody. So even prior to the pandemic and this shining a light on it, we know that behavioral health specialists are in short supply. I found these numbers really staggering. 60% of youth with major depression received no care for their mental health in 2017-2018. And over 55% of counties have no access to a psychiatrist, psychologist, or social worker. That makes it very difficult to access care, even if you're well enough or empowered enough to try and seek it. So on average, only 43% of people receive behavioral health treatment. The impacts of that are not only on the individuals themselves, but really the entire healthcare ecosystem and the entire community. So virtual behavioral health removes geographic, physical, and other barriers to free up clinician time and enable people to self-manage their situations more effectively. Virtual care and other digital tools have served as a lifeline for many in the recent months and are even more important in supporting existing care, providing scale, and increasing capacity as we go forward. What do these services look like exactly? So they come in many forms. You've got virtual clinician consults, which are really a traditional video consult. So they're going to replace an in-person office visit with synchronous or asynchronous video or audio visits. These alternatives to the traditional in-person therapy allows for a better match of supply and demand across time of day and geographies. Asynchronous messaging lets patients text a clinician or coach at any times and get a response later. Non-clinician-based digital mental health services like chatbots, self-directed learning content, gamified user experiences, online CBT, they're all a great complement to clinician-based virtual care and allow 24-hour access for individuals who appreciate that flexibility. Increasingly, innovative mental health services are combining digital tools and virtual care to create a robust end-to-end patient experience. That does involve referring them in person sometimes and as needed, but it does mean that so much can be done before they're seen in person. This combination really provides flexibility, it improves access and convenience, and it has been shown to be as, I don't know what that word is in English, the efficiency has been shown to be the same for certain conditions, which is very important. We definitely don't want to be compromising on patient outcomes by pushing a virtual modality. A study led by the VA showed that there was equivalent efficacy between in-person and virtual evaluations for depression and PTSD. And digital CBT has been shown to have similar efficacy rates for anxiety, depression, and insomnia as in-person CBT. So that's really exciting. If we can make behavioral health more accessible, we're going to really be changing lives. And if we think back to our quadruple aim, virtual behavioral health brings value by improving patient experience and improving outcomes. So now let's look at remote patient monitoring. So also known as RPM. Again, bad habit of acronyms. It's a professional habit. With RPM, we're going to be collecting and transmitting clinical data from outside conventional clinical settings. So now, between visits, whether they're behavioral or clinical, the individual is sharing information, often in real time, with their care team. So that can be your Apple Watch, that can be your smart blood pressure cuff, that can be your glucose monitor, you name it, the number of devices is growing every day. This is particularly important for individuals living with chronic conditions. The pandemic underscored the vulnerability of the 147 million Americans living with chronic conditions and the critical role of remote monitoring in helping them manage their conditions from the safety of their homes. Let's just put that again in numbers. 6 out of 10 American adults have at least one chronic condition, and 4 in 10 have 2 or more. So, and when we actually put that in terms of amounts, 90% of the healthcare spend in the United States goes towards care for someone with a chronic condition. That is pretty staggering. So the continued adoption of virtual visits is only really sustainable if you couple it with remote patient monitoring, because you need to have data on these folks who are living with one or more chronic conditions so that you can be ensuring that their care is safe and appropriate. So if we think about it, it's going to be actually so much better than in-person traditional care, because instead of having this very static snapshot of your weight and your blood pressure and your temperature only when you're in your physician's office, you're going to be having it in a continuous way shared with your care team. And so they can be coming in a much more predictive manner, applying AI and machine learning to all this data and intervening before your condition worsens and potentially avoiding a very costly emergency room admission or an inpatient visit. So thinking back through that quadruple aim again, we're lowering cost, we're improving outcomes, we're improving patient experience because they're able to access care from their home, and we're improving provider experience because they're able to better serve their patient population and have tools that help them do so. So now if we bring virtual care and RPM together to the next level, we're looking at hospital at home. So this is one I'm very excited about. I think more care should be happening in the home. So COVID has obviously accelerated interest and investment in hospital at home, which combines in-person home visits and virtual monitoring and virtual care to provide high quality acute care in the home. By bringing care to the patient, hospital at home programs, some of the most well-known are at Mount Sinai and Johns Hopkins, have been shown to lead improved clinical outcomes, less stressful and shorter lengths of stay, lower readmissions, and up to 20 to 40% cost savings over traditional inpatient care. Well-monitored at-home treatment can be safer, cheaper, and more effective than traditional hospital care, especially for patients who are vulnerable to hospital-acquired infections and other complications of inpatient care. Some studies have shown up to 70% drop in 30-day readmissions for certain conditions treated at home. So again, those really are pretty impressive outcomes. And actually, CMS is also pretty impressed. In March 2020, CMS announced the Hospital Without Walls program, which provides added flexibility to hospitals that are looking to provide services in locations beyond their existing walls. And in November, CMS expanded on this effort by executing an innovative acute hospital care at home program. So this program is supposed to provide eligible hospitals with new flexibility to treat eligible patients in their homes. They've also listed up to 60 different acute conditions that they consider can be eligible for treatment in hospital at home programs. Some of those are COPD, so chronic obstructive pulmonary disease, pneumonia, congestive heart failure, asthma, a lot of conditions that with proper monitoring can be done very well. So I don't think I need to beat you over the head, but obviously this directly addresses three aims: lowering cost, improving patient outcomes, improving patient experience by allowing them to receive care in their homes. Fun little tidbit, Bioformi, which is a startup in this space, became a unicorn this year. So that means that their valuation went over 1 billion and they had an over 100 million Series D. And also Mayo Clinic is pairing with Medically Home to build their hospital at home platform. So this is definitely gaining traction. So now I do want to address decentralized trials because I don't want to only speak about providers and payers. And telehealth and virtual care are really disrupting other corners of the health ecosystem. So IQVIA and VirTrial and other innovators in the pharmaceutical space have been pushing for this for some time, but this is now really becoming adopted by the entire pharmaceutical industry. So pharmaceutical trials have probably never received as much public attention as during the COVID vaccine trials. Trials are generally much longer and much less streamlined. It's pretty amazing what we can achieve when everybody has a common goal and there are a lot of resources. The average cost of bringing a drug to market in 2020 is about $2 billion, and only 1 in 10 actually make it to market. Half of this cost is actually due to the long timeline for drug development and driven by inefficiencies in clinical trial designs and implementation. I saw a stat, which I need to verify, but saying that obviously the majority of trials run late because they have trouble retaining participants, recruiting and retaining. And on average, each day that a trial is late costs between $600 million and $1 billion a day. I have not verified that stat, but that seems likely, but also pretty crazy as a cost to incur for the pharmaceutical trial, but also for funders and everyone else and society, because that molecule is not making it to market. So there are over 50,000 trials currently recruiting and enrolling patients, and most potential participants live over 2 hours from the nearest study site. Finding, recruiting, and retaining participants is a major pharma industry pain point, and medtech. Decentralized trials are about getting closer to patients and whatever demographic they may be from. and alleviating the burden associated with participating in the trial and addressing unmet industry needs. So decentralized trials allow people in rural areas to participate. They allow for better targeted recruiting if you're looking for a very specific population group. They also allow for a more diverse cohort so that you have better outcomes. They also improve retention. The average trial or traditional trial has up to 30% dropout rate, whereas a virtual trial has as low as 5%. That's pretty amazing. And for those of you who might be concerned that older adults are not interested in participating in these trials, remember how I said that they were the over 50 population was actually pretty interested in using virtual health? The AARP did a survey this year and shows that over 77% of older adults own a mobile device, and almost a third of it use it to manage their health or receive healthcare. And the percentage of them who own wearables is 17%, which may not seem that high, but the 18 to 49 age group is only 20% owning wearables. So really, it's pretty equivalent. And of course, always bringing it back to value. So this is also pretty clean cut. Improve patient experience by allowing them to participate more easily, improved outcomes by having more diverse cohorts and bringing molecules to market faster, lowering cost by promoting recruitment and retention, improving the odds that a trial finishes on time, and one could argue improving provider experience by ensuring that the scientist trial is going well and finishing on time. So I know I'm speeding through, but I do want to be sensitive and I want to make time for questions. So thinking about next steps. This is really key, right? You're convinced, I'm convinced. We live in a magical digital world and everything's transformed. Yes, and because virtual care is now part of the new normal, we really need to be thinking about more permanent structures and solutions. And as we think through design and implement, I really want us to keep a few things in mind as users and patients, as providers, as leaders and thought leaders in our spaces. This is key for all of us. So accessibility, really can't speak about this enough, but just as a backtracking. Obviously, we said it before, early days of social distancing were a little bit of a fire drill. Most of us had been trained in theory to follow some kind of established procedures, and most of those flew out the window, and we've had to rewrite and redesign and readapt all the time. So once we recognize that the situation is becoming more than just a transient window in time, we started thinking about how we can make these solutions more sustainable and have this digital transformation be more sustainable. So as we build out this new normal, I do want us to be thinking about accessibility. So it's crucial for us to think about how this digital transformation can happen without deepening the digital divide. Examples are numerous, and we can be speaking about social determinants of health all day long. But I do want to bring one up that's very obvious with regards to virtual care and digital transformation. Internet access seems simple enough, right? But 19 million Americans don't have access to the internet or broadband access at all. That's 1 in 4 individuals living in rural communities, and that's 1 in 3 living in indigenous communities. Then roughly 3 in 10 adults with household incomes below $30,000 a year don't own a smartphone, and more than 4 in 10 don't have home broadband service. So how are you supposed to access care, education, workplace, when you're limited in your access to the main gateway, which is the internet, or sustainable internet that is fast enough to allow you to do all of these things? Higher income Americans, in comparison, are more likely to have not only one device, but multiple devices that enable them to go online. And 2/3 of them have home broadband service, a smartphone, a desktop, and a tablet. So you're able to access, or most people with a higher income are able to access the internet and a lot of different resources in completely different ways. So we really need to be thinking about that impact. And people are, right? Mayo Clinic has actually started a program about making broadband more accessible in some of its communities. Elon Musk is working on it. So some great minds are really putting their minds to it, but that definitely needs to be something we keep in mind. Security and trust. The necessities of social distancing during COVID-19 outweighed privacy and security fears for a lot of us, as we were more concerned about not leaving the house than we were about HIPAA or about who I was sharing data with. In 2019, though, 89% of healthcare consumers trusted their doctor and other providers very much, or some, to keep their digital healthcare information. And that number has actually dropped in 2020. It's now down to 83%. And then if we start thinking about tech companies who are going to be massively involved in this digital transformation, more than half of consumers don't trust these companies to keep their digital health information secure. And what I found surprising is that the only group that's trusted less than tech companies is the government, with only 39% of consumers trusting the government to keep their health information secure. So obviously, we have some work to do to regain the public's trust, and we need to be thinking about that and building in security into everything we do. And I would say that although a lot of these fears are not always based in fact, there are some true security risks that the industry is facing, right? We've seen a 148% spike in ransomware attacks early in the pandemic. There was, you've probably been following the news with a lot of ransomware attacks focusing on healthcare institutions, and over 9 million health records were breached in September alone. It's it's a large group. So threats continue to rise in number and severity, and being able to use any device on any network at any time is an imperative, but keeping all data secure is really proving difficult. So we need to, again, start strengthening our stance on security and building it in rather than bolting it on as an afterthought. Integration. Integration of services and integration of data. I cannot say this enough. The digital transformation in care is bringing to the forefront that the hospital and the in-person visit are only one part of care, as we saw. The home, the community, the day-to-day environments are destined to play a central role in the healthcare system of the future. It is more than just care moving outside of the traditional four walls. It's really about having a continuous experience of care. Remember, right care, right time, right place, right cost. This means that ideally a patient is able to seamlessly transition between these settings. And that's not the case today. You might log on to a virtual care provider and it isn't linked to your PCP or to your payer. And so those two important stakeholders in your health don't have visibility on what happened in that consultation. And that virtual care provider can't seamlessly book you for an in-person appointment if you need one with your PCP, or even organize an in-person admission to the hospital. So there's a lot of doubled up work, a lot of fragmentation. So we really need to be focusing on that in order to ensure adoption, but also avoid fragmentation and doubling up of services. I know I've got 4 minutes left, so I'll go quickly. Integration of data. I don't think you need me to talk to you about the problems of data fragmentation in healthcare. It's a pretty well-trodden topic, but definitely one that we need to be thinking about as we increase the sources and the volume of this data. So obviously integration and all of these digital transformations come with an increased volume. We need to be thinking about how we can actually integrate that and derive insights from it rather than having it live in silos. And lastly, but not least, human-centered experience. So you'll notice that I use human-centered and not simply patient-centered. Don't get me wrong, absolutely need to put the patient at the center of care. However, this only really works if we put the human and the carer also in that mix. So historically, we've had a pretty captive audience in healthcare, but that's changing. Ruby mentioned it in banking. Very similarly, healthcare is experiencing a lot of consumer expectations, and we need to be thinking about the patient experience when we're designing any new service and thinking about the provider experience. If we think through the last digital transformation of the size and magnitude, which was EHRs, a lot of great things came from it, but it's also consistently mentioned as a cause and a contributor to clinician burnout. So how can we do better? So I know that was a lot of content, and I know we have 5 minutes. So if there are any questions, I'd love to take them now.
So let me ask you a question. Excellent talk, first of all. You can hear me, right?
Yeah.
Okay, excellent talk. So question, as I was listening to you, I was thinking about the forgotten part of this country, rural America, where hospitals have left and they don't have internet access. That's a very tough situation to address, right?
Yes, very tough situation.
Yeah.
Yes, I mean, I do think that we're seeing an interest in obviously accessing populations that are less targeted usually, but we just see that we really need to be thinking about equity in access, and that means thinking rurally, thinking about disabilities, right? I mean, rural is one, but we have 61 million Americans living with a disability. So how are we making sure that care that we are offering is really offering to all and not just offering to some, which traditionally have, that if we think about a demographic, and I'm a part of it, I work from home, I have a lot of access, and so traditionally a lot of these digital innovations have been targeted to me, the worried well, the worried privileged well. And so how can we be ensuring that we're casting a wider net?
Yeah, and it's surprising that even in cities like New York City, there's a fair amount of population, fairly sizable population with very poor internet access. And but in rural locations, there's no hospital nearby and there's no internet, so it's a double whammy.
Oh, my partner lives in Vermont, and so in most parts of Vermont, there is no cell phone access. There's not even just broadband. There's no cell phone reception. And there's actually a pretty amazing map of the US where you can layer in broadband or cell reception and healthcare outcomes. It's really fun if you are a data nerd and you like really dark material, if you have a very cynical sense of humor. I strongly recommend it, but it's really fascinating. I mean, I think that there's also, it just shines a light on just how much opportunity there is for us to truly make a difference. And sometimes the difference is not designing the latest AI algorithm. It's something as simple as enabling internet access in 2020 in a rural community.
Good. Any questions from anybody on the Zoom meeting?
So the question is, thank you for touching many critical areas in healthcare. Regarding human-centeredness, we need a doctor's human touch to heal. It makes me nervous to think that I will call a 1-800 number to get a doctor who cares about me as a person. Are there any major players promoting a mixed model where I can get the same doctor over the internet? That's a great question, and that's definitely key, right? If we think about integration, Santi, that is a must. Traditionally, virtual care has been separate and kept in parallel from in-person care, and really the care of the future is going to be integrated. So ideally, maybe it's not the same provider, but ideally you are seeing your provider in virtual and in person, or maybe you're seeing a nurse that you know really well and who's doing your triage and evaluating whether you need to be seen in person or virtually. So that, again, if you can be seen virtually, you don't have to be leaving your home, and your doctor can call you and make sure that your prescription is sent to your pharmacy. So the goal is really, I think, to integrate the two models. Every big player or every big provider and payer model that I know of that are doing well are doing that mixed model. But it becomes harder for smaller practices because then they have to be covering virtual consultations and in person, and they're often only one or a few providers. So yeah, it's hard to balance. How can we avoid every practice becoming a really large practice, and still enabling that mixed model of care?
Yeah, well, okay, thank you. One last question from me, and
Mhm.
then we'll move on because we are already at the time limit. I know you got a late start, so let's field one more question. So this is what are your thoughts on the long-term sustainability of virtual healthcare? Right now, we are in a crisis where there is no other alternative, so everybody's adopting it. Uh, do you think that in the long run, people will want to go for physical visits and give up on virtual visits with their doctors, or is this a trend that will continue?
I I mean, I'm biased probably, but I don't think that I am, considering the number of much smarter people who are saying it, right? It's no longer going to be about in person or virtual. They're all going to be part
It's
of
going to be
one.
blended. Yeah, yeah.
So it's, sometimes you'll see somebody virtually and sometimes you'll see them in person, and we'll just as when the telephone started, right, the in-person visit, the traveling doctor no longer needed to come to your house, potentially for something benign and small. They could do it over the phone. I think we'll start seeing a lot more of that, in terms of that really seamless handoff between virtual and in-person, with your provider. But obviously a lot to do before we can get to that.
Good.
I don't want to run into the next speaker's time. Thank you
All
so
right.
much for having me, and I
Certainly.
look forward to continuing the
Thank you
conversation.
for the great talk. Thank you.